Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemorrhage.
And let's get started on today's topic.
From basics
to brilliance. Hi David, how are you?
Good, thank you, Harry. Looking
Excellent.
Forward to wrapping up some Haemophilia A.
Yeah, exactly. So we're on to the next stage of sort of management of haemophilia A, and I thought today we could talk a bit about dilemmas in haemophilia management. In particular, how to we'll start with some cases, but today's topic is all about kind of the things that you do actually get called about as a haemorrhage.
I was going to say this sounds like Mind the bleep, but for haemorrhages.
Yes, exactly. So let's open with our first case. These are all made up. So, but based on things I have been phoned about. So this is a 41-year-old gentleman who has a diagnosis of severe haemophilia A, and he develops chest pressure developed by proper chest pain with some associated shortness of breath. And he comes to A&E where he has an ECG, which is an ST elevation. He's got a troponin of 4,000, and you get a phone call from cardiology because they want to take him for PCI.
Grand.
Lovely. What are your thoughts or like alarm bells about that?
So I guess the thing that I'm thinking about first is how severe is his haemophilia? Mm-hmm. What's he previously had? And how effective has it been? Because I'm worried that we're going to give him a boat ton of anticoagulants now, and he is going to bleed all over the shop. Mm-hmm. I know, like the MI is quite, clearly the big thing, thing to manage. Yeah. But the last thing I want to do is, poke a hole in his bucket, and then exactly. Cause some other hideous problems.
Yeah, exactly. So before we talk specifically about the management of MI in haemophilia, I think it's helpful to have, and I've kind of taken this from one of the how I treat papers in haemophilia, but they've got a really nice way of looking at breaking down any problem like this into 4 steps. So they say whenever you're considering anti-thrombotic therapy in patients with haemophilia, evaluate 4 key principles. So what do you think the first one is going to be? You've kind of said it, but...
bleeding risk.
Yeah, exactly. So how bad does the patient bleed, essentially? So this gentleman, for example, has got severe haemophilia. So we know already that his factor levels are going to be less than 1%. But we also want to know from his history, like how frequently does he bleed? What's the severity of the bleeds that he has? Are they spontaneous or are they provoked? Is he on replacement factor prophylactically, or has he stopped that given that he's now 41? And then the other thing to do with how bad does the patient bleed is also how well do they respond to treatment. So are there any particular patients that you might have a bit of a red flag in your head for anticoagulating in particular with haemophilia?
I guess are people with sort of refractory haemophilia and people with inhibitors.
Inhibitors, yeah. So inhibitors is the big thing, which I guess in a way your term refractory is kind of...
I've just stuck that in. I don't think that's the thing.
Inhibitors, exactly. So that is going to be your concern is any anticoagulation or antiplatelets in a patient with an inhibitor. You're going to be worried because you're not 100% confident that you'll be able to stop the bleeding. And so therefore your kind of riskometer of anticoagulating them is going to be edited by that. So I would say patients with an inhibitor generally outweighs any potential benefit to anticoagulation. So we generally would avoid anticoagulating patients with an inhibitor most of the time. Okay, good. So that's the first thing, is how bad does the patient bleed? Second thing that you might consider, David, as a general principle?
I guess what they're on, whether they've got the sort of which type of factor rate they're on, how long it lasts, that kind
Okay.
of thing.
Yeah, I
And
would
what,
I would
what
lump that under how bad does the patient bleed, because
okay,
that's really kind of assessing their background risk of bleeding. If they're on long-term prophylaxis, as you say, then their risk of bleeding is going to be lower because they're already on prophylaxis. So I would kind
okay,
of think about all of that in terms of how bad does the patient bleed at baseline
yeah,
before we touch them.
okay. And then I guess what we're going to give them.
Yeah, in terms
Are
of
we going to give
anticoagulant
them,
or
yeah,
antiplatelet.
ticagrelor and
Yeah,
dual
exactly.
platelet antiplatelets? Yeah,
Exactly. So it's the characteristics of the anticoagulant is the second thing you need to consider. And with this, you need to think about the specific bleeding risk associated with the anticoagulant that you choose. So, warfarin is known for its intracranial hemorrhage bleeding risk, for example, versus DOACs, a more increased risk of GI tract bleeding, and what the risk for that patient might be. Reversibility is another big thing to think about. So obviously warfarin is very reversible with Vit-K and also with prothrombin complex if you needed to. And the other one that's good in terms of reversibility is dabigatran, because you
yeah.
can use Praxbind, the idarucizumab. Obviously apixaban and rivaroxaban do now have a reversal agent, but it's only available to be used for GI bleeds, life-threatening GI bleeds. So I would say that's less of a reversible DOAC in my head, at least in the NHS anyway. And then the other thing you need to think about as well as the bleeding risk associated with the anticoagulant, the reversibility of the anticoagulant is also the half-life. So that's sometimes where you might choose to use unfractionated heparin over low molecular
Yeah.
weight heparin, for example. And generally, the general consensus from reading a couple of sort of guidelines and papers, there's no overall BSH guideline for this, by the way, because this is all going to be a big grey area and a lot of MDT discussion for these patients. But in general, the consensus is that anticoagulation is generally okay in haemophilia patients if their factor 8 or factor 9 levels, their trough levels are above 30%. And that's with or without prophylaxis. So if you've got a mild haemophilia, then they're probably going to be okay to have anticoagulation. If you've got a severe haemophilia A, but they're having regular prophylaxis and their trough levels are kept above 30%, which is a lot higher than we would normally keep trough levels,
Mm.
then they would be okay to have anticoagulation. So 30% is the general number I have in my head for that. And then for antiplatelets, low dose aspirin is like your lowest risk antiplatelet in terms of bleeding. And generally, the consensus is if you've got factor VIII levels above 5% or equal to 5%, then you're probably okay to use low dose aspirin. But if you had levels of like less than 5%, you probably shouldn't do it. And dual antiplatelet therapy, they say the equivalent bleeding risk is that of an anticoagulant. So again, they're saying trough levels of above 30% for dual antiplatelet therapy. Okay. So that's a general approach to the characteristics of the anticoagulant that you need to consider. So we've considered how bleedy is the patient, how bleedy is the drug that we want to put them on. What else would you consider?
Um, I'm not sure what else, I guess.
Okay, so the third thing that they kind of have as an umbrella term to think about is the intensity of the anticoagulant therapy.
Okay.
So the dose, basically, what you're using it for. So low intensity being prophylactic low molecular weight heparin, for example, to prevent a VTE event for an inpatient post-op, for example. So do you know what factor level we generally use to say they should have VTE prophylaxis?
Sorry, say that again.
Do you know what the rough factor 8 level or factor 9 level needs to be above for us to give them routine VTE prophylaxis?
Um, no idea. No.
No, that's fine. It's 50. Generally, we
Okay.
say 50, and that confuses people because when you've got people coming in for elective surgery and you're giving them a, factor replacement plan, you're giving them the infusion before the operation, you're checking their levels in the evening, you're giving them a bit more factor, usually like half the dose usually that you gave them pre-op. You're then saying, oh yeah, don't forget to give Inhixa prophylaxis, and they're like, what? But it's
Yeah.
because we know we're maintaining the level above 100, so therefore they are at increased risk, like any other patient in hospital post-surgery, of having a VT. And obviously, we really want to prevent VT. So if it's a low intensity anticoagulation, like prophylactic anticoagulation to prevent a VTE, then I would say over 50. That's generally what we do in our hospital anyway. And then you've got other intensities, so like a standard intensity, so for treatment of a VTE, And then you've got your high intensity of anticoagulant therapy, which is sort of what you see in, ACS, primary PCI, where they're giving a bolus of unfractionated heparin.
Yeah.
So yeah, and just thinking about how can we minimize the amount of time in the high intensity anticoagulation. So that's intensity of anticoagulant therapy. And then the fourth and final thing that they say to consider in any kind of situation where you're considering an antithrombotic in a haemophilia patient is the duration of the planned therapy and how can you
Okay.
minimize that duration. So, obviously, normally your duration of an acute VTE, the anticoagulation is 3 months, and that's because we know after 3 months that risk drops right down of recurrence. But in haemophilia patients, you may get away with 6 to 8 weeks. So it's a real risk benefit depending on the patient. So yeah, obviously, with all of these queries, these are not easy decisions to make. You need to involve the patient. They need to go through a hemostasis and thrombosis MDT. And it's kind of a risk discussion with the patient, and then often involving other teams to see if there are alternatives that we can use instead of anticoagulation or things that we can do to minimize the duration or the intensity of anticoagulation. And then choosing the least bleedy anticoagulant. And then also considering how bleedy the patient is. So those four things. Yeah.
Grand.
Okay, great. So, what do you think what do you think about cardiac disease and haemophilia? Do you think it's a common problem having ischemic heart disease in haemophilia patients?
I'd like to think less so, but I guess common things are common, and just because you have haemophilia doesn't mean that you're sort of going to escape having, coronary stenosis and things like that. So I
Yeah.
imagine it's probably less than the average, but probably still pretty common.
Yeah, and it's interesting you say that. So the lifetime prevalence of cardiovascular disease in people with haemophilia is estimated about 19.5%, which equates with about 15% of over 60-year-olds with haemophilia. And this is something that we're seeing more today than we were seeing previously, probably for a number of reasons. Lifestyle reasons, everyone's getting a bit more overweight and having hypertension, all of that. But also, thankfully, our patients with haemophilia are living much longer than they used to, with good haemophilia treatments and a lack of giving them HIV and hepatitis C and B, for example. And so therefore, we are now seeing a lot more of this in patients that we would not have necessarily seen before. And it's interesting that you were saying about how, because there's quite conflicting data as to whether haemophilia protects you from ischemic heart disease or not, because obviously the disease process itself in ischemic heart disease is of the arteries rather than the veins.
Yeah,
So
platelet
it's a
based.
separate
Yeah,
thing. It's platelet based, exactly,
yeah.
and it's based on how much atheroma you have and whether that plaque chooses to rupture, which has actually got nothing really to do with your clotting factor levels. However, initially people felt that it might provide protection. There
Yeah, I
was
was
this
going to
large.
say you hope you get a little silver lining for having a genetic problem,
Yeah,
but maybe
exactly. So the incidence actually has been shown in studies to be the same of having ischemic heart disease if you've got haemophilia A than if you're any other person without haemophilia A. But there is a suggestion from some data that they have a reduction in mortality from ischemic heart disease. So the incidence might be the same, but the mortality might be lower compared to the general population. So there was this large systematic review of 19,000 patients of haemophilia A. I think they included carriers and they did haemophilia B and von Willebrand's, and they showed a reduction in mortality from ischemic heart disease compared to the general population. And they said that was probably because they had fewer occlusive thrombi occurring after the plaque had ruptured. That was their kind of theory because of the low factor VIII and factor IX, which makes sense. However, more recent data suggests that actually the prevalence of cardiovascular disease and MI was twofold higher than in patients without haemophilia. And they said that was probably due to, lots of clotting factor concentrates being provided, co-infections with HIV and antiretroviral therapy being a risk factor, and just higher levels of hypertension, diabetes, a high BMI, and a lack of physical activity. I guess in a way because their lifestyles have probably had to be adjusted to not be playing rugby and, doing necessarily high impact sports and stuff. So basically it's a bit of a mixed jury and the data's quite conflicting, but it's interesting to think about. And the most important thing is that actually it is important, and it's not insignificant, the numbers of people that have ischemic heart disease with haemophilia. Okay.
That's interesting. That's
Yeah.
interesting. Especially now that, I guess you don't think about that whole cardiovascular risk factors going up because they are wrapped in cotton wool.
Exactly.
And yeah, I guess particularly in the past, I suppose, where the answer was just do nothing.
Exactly. Yeah. So in terms of patients with a STEMI in ischemic heart disease,
Yep.
obviously the normal treatment would be PCI, and that would
Yep.
involve unfractionated heparin infusions during the procedure.
Yep.
In general, the guidance is, the consensus, I should say, is that we probably should still do PCI for patients with haemophilia A.
Okay.
But what we have to do is give factor VIII to get the levels to 80% to be able to facilitate that.
So we treat it like an operation, effectively.
Exactly, but it's a bit more bizarre than that, because you're basically
Yeah.
providing factor to then anticoagulate them.
Yeah.
But the analogy that I like to think about it is, you may have come across patients on a haematology ward that have somehow developed a PE or a DVT with platelets of like 3, or they get a line associated infection, they've got like less than 10 platelets. And in that situation, you might have seen it, we give platelets basically daily to facilitate anticoagulation. And so it's a similar thing. Sometimes you do have to give product to facilitate anticoagulation, which seems bizarre, but that's what we do. So you would give factor VIII to get your levels to above 80%. And is there anything else you would, are there any patients that you would really worry about doing this to, first of all?
I suppose the severity thing
Yeah.
again.
Yeah.
And then inhibitors as well, because I'm
Yes,
not sure how.
inhibitors.
Yeah.
It's
So
always going to be
yeah.
inhibitors. Inhibitors are the one we
Yeah.
worry about, which is why we talked all about immune tolerance induction and everything last time,
Mm,
for exactly reasons like this, where it's
yeah.
so much better to not have an inhibitor. Patients with inhibitors can still have PCI, but obviously you're going to have to use something like Nova 7 to get
Yeah.
your factor levels up, and you're not going to know what your actual factor levels are before you
Yeah.
go in and do PCI, which is the whole kind of problem with
And
that.
just for clarity, Nova 7 is the recombinant, activated recombinant factor 7 that
Yeah.
bypasses our 8 problem.
Exactly,
Yeah.
exactly. Yeah, that's exactly it. So you can do PCI, but you have to give a big dose of Nova 7. Obviously, Nova 7's got a half-life of, like, I think we said 2 hours last time. So you're like 2 hourly dosing. And then you need to keep doing that for 24 hours, and then go to a slightly less intensive regime, but still a daily infusion for like 4 weeks. And inhibitor patients, you would also only go for a single antiplatelet whilst you're bypassing their inhibitor. Okay. So those patients I would worry about. Other things that you can think about that are not to do with factor replacement and anticoagulation. When they do PCI,
Um,
where do they normally go in? Do you have?
femoral.
Yes, exactly.
So
And
can you go radial? Can you be a little
yes,
bit kinder?
yeah,
Okay.
exactly. And the benefit of going as a radial approach is that you can
Mm.
apply pressure a lot more
Okay.
easily. As if you go as the femoral approach, you can get retroperitoneal bleeding. So that's
Okay.
important to think about. And actually, just advising people, make sure you apply loads of pressure for a prolonged period afterwards is really
Mm.
important. People often forget that, like, when people are bleeding, the first thing you need to do is just apply really good pressure. Good. And then in terms of then putting in a stent, would you prefer a bare metal stent, or would you prefer a drug eluting?
I would love a drug-eluting stent, please.
You'd like a drug eluting stent
Oh, sorry,
for
you
you
said
or
stent
somebody?
for stent for stent. Sorry, I'm just thinking valves. Valves require
Yeah.
high iron. I have no idea.
So
Literally no
you
idea.
you would go for a bare metal stent, which you wouldn't normally
Okay.
do. And the reason why is because the bare metal gets endothelialized quite quickly.
Okay.
And therefore your duration of antiplatelet required is only a
It's
month.
less.
Yeah.
Ah,
Instead of a year of dual antiplatelet therapy, which is recommended with drug-eluting stents. Um,
interesting.
yeah, so you would advise that they put in a bare metal stent to reduce the duration of anticoagulation needed. Um, and then you're going to maintain your factor VIII level above 80% and a trough above 30% for at least 48 hours after the procedure as well. So it's going to be lots of factor VIII levels and lots of factor VIII replacement. So you're going to keep your hemostasis nurses busy. Um, and then in terms of dual antiplatelet therapy, the general consensus is, I know before we said above 30% as a rule of thumb, But in some guidelines and some discussions and papers, they say a trough of 10 to 15% is fine to allow you to give dual antiplatelet therapy for sort of 4 to 6 weeks, basically. Especially if it's a bare metal stent, you could get away with 4 weeks. And then aspirin, as we said before, you can give aspirin if their factor VIII is naturally above 5%. If it's not above 5%, you're unlikely to replace factor indefinitely just to allow a single antiplatelet agent. And then don't forget a PPI.
Yeah.
And PCI is preferred over thrombolysis.
Yeah.
Yeah. So those
it's one of those. It's worth saying.
It's worth saying. It really is. Yeah. As is applying pressure and the radial approach. So those are the things to remember. Okay. So should we go back to our first case and kind of discuss how we would treat him? So he was 41 with severe haemophilia A and had had a STEMI. So what are we thinking, David?
So severe. We want to take him for a PCI. He's had a STEMI. So we're going to give him factor VIII, aiming for a peak of over 80%.
Good.
Radial approach. Yeah. Using unfractionated heparin, preferable. We're going to apply lots of pressure afterwards.
Yeah.
We're going to start him. If he maintains a decent trough level afterwards, we're going to start him on double antiplatelet therapy for 1 month, and then drop him down to aspirin after then.
And would hopefully we do aspirin for him because he was severe?
Oh, he was severe. No, we wouldn't. We wouldn't maintain him to give it.
Exactly, and we maintain that factor VIII level above 80% and a trough of above 30% for 48 hours post procedure. And why are we only doing a month of dual antiplatelet?
Because we've given him a bare metal stent instead of a drug-eluting stent.
Exactly. And then don't forget your PPI. And brilliant. Okay, good. So, I mean, I'm not saying that's that's not like the guidelines. That is going to be really independent for each patient and discussed with the patient and discussed with the cardiologist and discussed within the MDT. But that is an approach that you can take to this case. And it just makes it feel slightly less scary discussing a potential approach, if you know what I mean.
Yeah. I guess my just from a pragmatic point of view, you know, are we going to know his trough levels and things like that when they present? And clearly they're going to want to take him to the lab as soon as possible for the idea of us going, oh, can we go and have an MDT? You know, is that going to be?
Yeah, you're right. The MDT is not going to be available acutely when you get phoned.
Yeah.
You are going to go and talk to your hemostasis and thrombosis consultant, and I imagine they would discuss with their colleagues and just get a rough idea of what check everyone sort of agrees with the plan and that the patient agrees with the plan. In terms of trough levels, this man's not going to be on prophylaxis because he's 41, so it's unlikely to be on prophylaxis usually at that point. So that's where it will also come into whether the patient's agreeable to have prophylaxis, even for, he's going to have regular factor replacement for the next month just to facilitate dual antiplatelet therapy. But you've got to weigh up the risk of not treating an MI.
Yeah, for sure.
Versus bleeding. And, it's not clear which one might kill him first. So you're not going to
I know which one the cardiologists would
You're not
say.
going to MDT straight away, but you would, the MDT would be able to help after that acute management. The week later and you've got your MDT, you could discuss what you all feel is the most appropriate. You'd have levels on the system to know what level of his, anyway that he's a severe, so it's sort of irrelevant.
Yeah.
Does that make sense?
Yeah,
it's all a bit grey and woolly.
Challenging, isn't it? Yeah, because clearly this is
going to be like that because it's not easy.
Yeah, this is clearly the 4 a.m. phone call because everyone has an MI at night.
Yeah, exactly. You're right. They wake up.
Should I have an MI at 8 a.m. so everybody's fresh and ready?
I've not been called about that yet, but I feel like I've jinxed it now.
Yeah.
Okay, right. Case number 2. Are you ready for another conundrum?
Yes, come at me.
Okay, so this time it's a 60-year-old male. Obviously, they're all male because it's X-linked. This gentleman's got haemophilia A. He has a factor level on the system of 2% or 2 international units per DL. And he presents with palpitations. He's got a background of being a smoker and having hypertension. He's got a family history of stroke. And when you examine him, or when A&E examine him, he's got an irregular pulse, and the ECG shows that he has AF. So, what are you thinking here, David? What would be your normal approach, and then what's making you worried?
So I guess I would do a Chad Vask.
Okay, yeah.
And then I would get myself a number, and it would give me a nice, give me a risk associated thing and some advice about starting a DOAC.
Yeah.
And whether I started him on sort of a treatment dose DOAC, if he's got sort of a paroxysmal presentation. But he's a bleeder.
Yeah, exactly.
And I don't know where he lies on the risk benefit.
Yeah. Is the has bled something that we can use?
You may have to remind me about the has bled.
So the has bled score is, the standard score that medics kind of use to balance up the risk versus benefit of anticoagulation AF. So you have your CHAD-VAS score and then your has bled score. And I think medics kind of the has bled score was never designed to contraindicate anticoagulation, but essentially it seems to be interpreted in that way. So if you've got more bleeding risk than you have stroke risk, then they tend to just not anticoagulate. So basically the has bled score is obviously not valid for patients with haemophilia because it's going to massively underestimate their risk of bleeding. So we can't use it. And the big problem of AF in haemophilia is that there is no validated scoring system either for bleeding or for stroke risk in haemophilia A. But we do use the CHAD-VAS to kind of still assess whether that patient would benefit from anticoagulation potentially. And the standard thing applies that a CHAD-VAS of 2 or above probably should be treated with anticoagulation. There's no role for anticoagulants in haemophilia for reducing stroke risk, but nor is there in normal patients without haemophilia. So that's just, this whole thing about using aspirin to reduce your risk of stroke, if you've got AF, is not appropriate. Okay, so just using our 4 key principles that we talked about at the beginning, how bleedy is the patient?
So 2%, which makes him moderate.
Yeah, okay, brilliant. So 2%, but that's going to be too low on its own to anticoagulate because we said sort of 30 and above would really be what would make us happy to start an anticoagulant routinely. Characteristics of the anticoagulant. So what are you thinking you might want to use in this situation?
I'd like to give him a DOAC.
Yeah, okay. Yeah, I mean, DOACs are better over warfarin in terms of intracranial hemorrhage risk. So, yeah, fair enough. And there's no obvious GI bleeding risk. So that's good. And then intensity of anticoagulation therapy.
So I guess it's treatment dose, isn't it? So was that high?
Yeah, I mean, it's normally treatment dose, but you can get away with using the lower dose DOACs in these patients. Well, I don't know if you can get away with it is the right term because we're in a pretty evidence-free zone here. But the risk benefit probably favors using the lower dose DOAC than the higher dose.
Okay.
So like 2.5 BD of apixaban rather than the 5 milligrams that you would otherwise use.
Yep.
Okay. And then the other thing that we needed to consider was the duration of therapy, which obviously in terms of reducing stroke risk,
it's lifelong.
Yeah.
So that's a non-starter.
Yeah, exactly. So, and I know we said 30% before as in terms of a level for anticoagulation, but there are some separate AF kind of discussions in various papers which talk more about a level of 20%. So some people would be happy to go down to a factor level of 20. That still help us with our man, but they would say less than 1%, so severe haemophilia, don't do it. Don't anticoagulate just to reduce the risk of stroke. Between 1 and 20%, big grey area, so that's helpful because that's where our patient is. And then above 20%, they would say you're probably okay to use a low dose DOAC. So we're in that grey area. And I guess the problem with something like AF, unlike PCI, is that you are looking at a longer duration of anticoagulation, or otherwise maybe don't bother at all.
And I guess the thing is the stroke, the outcomes can be hideous, can't they? You have a big MCA stroke, it's completely life-destroying.
Exactly.
So it's a difficult one.
What other things can you think of, David, to avoid anticoagulation in this situation? Like reduce the patient's stroke risk?
I guess things like ablation. Could
Yes,
you go for a
exactly.
different, yeah, instead of,
Exactly. So you really got to involve your MDT here in terms of calling your cardiology friends and saying, can you not just ablate something to stop this irregular rhythm? That's as far as my cardiology knowledge goes. Um, cardioversion wherever possible as well.
yeah,
Although note that if you are going to do these procedures, you are going to need
need
factor
to
replacement.
anticoagulate them as well.
Yeah, well, exactly. And then the other thing you can do is left atrial appendage occlusion. And that's good for patients at high risk of stroke and bleeding because your a recent paper that was actually just published this year showed that the duration of anticoagulation that you need around a left atrial appendage occlusion is just 45 days. So that's quite a nice limited duration where, like, even in your really severe haemophilia A, you might consider, I guess, giving
Yeah,
prophylactic factor 8
that's it. You can
to
support your way
facilitate.
through that, can't you?
Exactly, exactly. So, yeah, so just don't forget to use your four things. Think about how can we limit the duration of anticoagulation or avoid the need to anticoagulate at all, which would obviously be the ideal situation.
Yeah,
What dose or intensity of anticoagulation are we going to use? What anticoagulant are we going to use? And how bad is the patient's risk of bleeding? And again, which patient type would you be really worried about anticoagulating just to reduce their risk of a stroke?
the nasty inhibitor people.
Exactly, exactly. So I feel like we're getting a good flavor here of the fact that inhibitor
Yeah.
is not good, which is why, you know,
I guess, like you said last week, last week, whenever you listen to the last episode, listeners,
yes,
talking about sort of the tolerance therapy sounds rubbish. You know, you
yeah,
have to go in
yeah,
so often and have
yeah,
so much factor.
yeah,
But actually, if down the line it can prevent issues like this with
yeah,
comorbidities,
exactly,
suddenly it pays huge dividends to sort of
exactly,
to get your tolerance up.
exactly. It's seen as a long-term investment, definitely. So let's go back to our case of our 6-year-old guy with AF then, with a factor
Yeah.
level of 2%. What are you going to do? What's his CHA2DS2-VASc score going to be? I'd calculate
So
two.
okay, yeah, I've got no let's say it's two,
I
given
think
I
it's
don't
two.
have
Yeah,
ND
one for
calculator in front.
hypertension, one for male. So therefore, he
Okay,
does warrant
so
anticoagulation.
yeah, so I guess I would like to give him a DOAC.
Yeah.
However, I don't want to give him full dose DOAC if
Mm-hmm.
I can get away with 2.5 milligrams
Yeah.
BD.
Yeah.
And then have a word with the wider MDT
Yeah.
regards other ways of fixing. Can he be rate controlled? You know, a bit better. Can it be ablated?
Mm-hmm.
Could we consider doing left appendage occlusion? So
Yeah,
yeah,
exactly. Yeah, brilliant. Exactly. And just don't forget about lifestyle stuff because, that's all going to help as well. So
yeah.
blood pressure control, diabetes, losing weight, doing some exercise. Yeah. Good. Okay. So basically, in summary, CHA2DS2-VASc score of less than 2, don't even think about anticoagulating. CHA2DS2-VASc
Yeah.
score of 2 or more, and their baseline factor levels are below 20%. Then if they're less than 1%, don't anticoagulate. So if they're severe, don't anticoagulate because you're not going to put them on, replacement factor to facilitate that for the rest of their life. If they're between 1 and 19%, that's a bit more tricky. See if there are other options that you can do, like, as you say, left atrial appendage occlusion. And if their levels are 20% and above, or some people would say 30% and above, then you could consider a low dose DOAC to reduce their risk of a stroke, along with all of the other lifestyle and like modifiable risk factors for a stroke. Good. Great. Any questions about that, David?
No, another life saved.
Okay, right. So last one. Are you ready for another conundrum?
Yes.
So the third case is a patient with haemophilia A who has been admitted electively for a lobectomy. And his levels are usually 2%. And we have given him factor 8 to replace to 100 to allow the operation to go ahead. He's day 1 post-op and he develops a swollen left leg and he's been diagnosed with a DVT on a Doppler ultrasound scan. What are you thinking, David? What do you think you might want to do and what are you worried about?
Okay, so provoked DVT, I think to say.
Yeah.
So I'd like to start anticoagulation. I guess I also want to cover him with factor 8.
Mm-hmm.
I want to know what his trough level is.
Mm-hmm.
And then I would probably like to give something with reduced duration, so like unfractionated heparin.
Like a reduced half-life.
Yeah, sorry, that's,
Yeah,
a
yeah,
reduced
yeah,
half-life.
yeah, yeah.
Use your technical words,
Yeah,
Stephen.
yeah. I can read your mind. Don't worry.
Yeah.
Yeah. Okay. Exactly. So, um, you're right, it's provoked. And actually, on that note, it's very rare to develop an unprovoked VTE event in a haemophilia A patient, particularly if they're severe or moderate. And usually it's due to clotting factor replacement, or in this post-operative period, or in this case, due to a combination of both. Studies have shown that high factor VIII levels, like above what you would aim for, are a well-established risk factor for VTE, with a relative risk of thrombosis of about 4.8, particularly if your factor VIII levels were above 150. And it kind of highlights the importance, this case, of not overshooting. We always worry about undershooting and patients bleeding, but there are consequences to overshooting as well, which again is why patients with inhibitors, if we can use Obazor so that we can titrate levels, then it makes us feel better than using something like Nova 7, where we're just like chucking a load of factor and not actually knowing where they're at in terms of levels. So I'd be interested in this case to know what his levels went up to so that we can, identify that as a risk factor and manage that and make sure we're not overshooting the target of 100 whilst he's still in hospital. And then, yeah, you said potentially using unfractionated heparin. I think that's a really good point, David, because particularly in that first 24, 48 hours, you are going to have to anticoagulate this guy because otherwise he might die of a PE. But using unfractionated heparin with its half-life of like 45 minutes means that if they do bleed, you can stop it and it will be out of their system relatively quickly. And then generally we would aim to switch to, well, some people would favour warfarin, some people would favour a DOAC, it depends really. But duration of anticoagulation, what do you think we're going to go for?
So I'm guessing provoked is usually 3 months, but this is dodgy bleeders. So 1 month, 4 to 6 weeks.
Yeah, exactly, because the risk is already dropping off by 1 month of recurrence. So I think if they're tolerating it well and they've got mild haemophilia, then you could consider completing 3 months, but otherwise 1 month is usually adequate. And you're going to use factor replacement to get your trough levels above 30. So it's that number 30
Yeah.
again, is kind of the bare minimum factor level that we want to be able to then anticoagulate. So a month of factor replacement seems doable. So even for your severe haemophilia patients, that's probably what you're going to end up doing to prevent them from dying of a PE ultimately. But what do you think, in somebody that had an inhibitor, for example? I mean, obviously, I've been banging on about it this whole time. We'd be nervous to anticoagulate them. Is there anything else you might consider if this man did have an inhibitor?
So I guess like we did with the heart, we looked for alternative
Yeah,
measures.
yeah.
So could we consider like an IVC filter?
Yeah, exactly. And like RVC filters generally are not the answer because they're actually, everyone thinks they're like this magic thing that stops you getting PEs, but they're not, and they increase your DVT risk and they need to be removed and they should be a temporary thing. But this is a situation where actually an IVC filter might be beneficial to reduce his risk of a PE if you weren't going to anticoagulate for whatever reason because they had an inhibitor, for example, and you were worried about bleeding. Good. Yeah. So that's just generally it in terms of how you would manage a VTE. So we've covered sort of three
Do you
major.
mind if I just ask? I've jumped you with this question.
No,
We didn't
please.
discuss it beforehand, so
No,
I do
no,
apologize.
that's okay.
Um, Imagine he had a massive PE and we were considering thrombolysis. He was
Yeah.
in, life-threatening shock.
I mean, I guess you would give factor replacement and thrombolysis at the same time.
Okay.
I haven't come across that before, but I mean, you gotta if they've got a
Yeah,
life-threatening
yeah, yeah.
PE and they're meeting the
That's going
criteria
to kill him
clinically for
first, isn't it?
thrombolysis, it's gonna kill him first. Yeah.
Yeah.
And it's not like you can't replace the factor. I mean, God, if they had an inhibitor, that would be really quite tricky. But then
Like
they
the
still just
Darwin
have to,
Awards.
I know you just have
Yeah.
to, you'd have to
Yeah.
just throw, Fever or Nova 7 at them with thrombolysis, I guess, if they had an
Yeah.
inhibitor. Yeah, that's really tricky.
That's a cool the wake the boss up
No,
scenario.
definitely. These are all wake the boss up scenarios, to be honest, because there are no guidelines. The information that I've got has been from, ASH good practice papers and how I treat
Mm.
papers rather than any kind of BSH guideline. So It's all going to be very individualized to the patient, their compliance, how willing they are to take factor replacement, how worried they are about bleeding, everything. Okay.
Cool. Thanks.
No, that's fine. So hopefully that's made that slightly less scary if you get phoned in the middle of the night, because we've at least kind of had a think about it rather than just thought, what? They're a haemophilia patient. No, you can't anticoagulate them, but actually sometimes you can. So should we wrap it up as 3 golden nuggets?
Yes, please.
Okay, so I'd say the first golden nugget is that we can treat patients with haemophilia with antithrombotics, so either anticoagulants or antiplatelets if it is needed clinically for either ischemic heart disease, AF, or a VTE. But we need to support them often. And so it's about finding that balance that's tolerable to the patient of giving replacement factor VIII and then anticoagulating or antiplateleting them. Roughly the cutoff is about 30 RU per DL as your level required of factor VIII or factor IX to be able to anticoagulate a patient safely, and a level of above 5% or 5 IU per DL for a single agent antiplatelet. And for dual antiplatelet therapy, they say it's roughly the equivalent bleeding risk of anticoagulation. So again, it's going to be that kind of 30% or 30 IU per DL level. That's just roughly in your head. Secondly, always ask yourself, can we be doing something else? So in AF, can we do left atrial appendage occlusions? Can we do ablations? Is there something that we can do to avoid the need for anticoagulation, particularly for AF, because it's lifelong anticoagulation that you're discussing? And therefore, no, we can't support factor VIII necessarily lifelong to allow someone to be anticoagulated. That doesn't really make sense. Or can we use an IVC filter, for example? Or can we address their other lifestyle factors like obesity, hypertension, smoking, alcohol, exercise, etc.? And then thirdly is always involve the MDT. Escalate to your consultant. Your consultants will probably chat amongst each other, involve the cardiology team or the stroke reg or, whoever it is. Make sure that you're involving lots of people because these are really difficult decisions and the patient will benefit from information that can be provided from different teams on these issues.
Lovely. Great. And if there was a fourth, it is don't get an inhibitor because it just makes things worse.
Yes, exactly. See reference to previous podcast on exactly that. Yeah.
Don't get an inhibitor, folks.
Yeah.
That's the big takeaway.
Yeah. Great. All right. Well, I hope that was helpful, David. And
yes, thank you. As ever, you've been incredibly informative and pragmatic, which we're grateful for.
That's okay. And I'll see you next week for pregnancy in haemophilia, and that will wrap up our haemophilia A discussions. You'll
Amazing.
Be glad to hear.
Oh, onwards to other things.
Yeah. See you later then.
Cheers. Bye.
Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.